Okay, so a couple of housekeeping items first. We are not drinking vodka up here, it's water. So there, my wife's here, and that's my joke, honey. But why don't we, first to start out, just why don't you introduce yourself and say a little bit about your organization and your perspective on who is paying for medical errors.
Thanks, Joel. My name is Graham Billingham. Thank you very much for having me here today. I'm excited to be here. Thank you mostly for your passion and your commitment to this movement. I'm an emergency physician by training. The opportunity in early 2000s to chair the Emergency Medicine Patient Safety Foundation with some colleagues that are here in the audience. Learned a tremendous amount about risk, quality, and prevention. And my current role of Chief Medical Officer for the Medical Protective Insurance Company, we insure hospitals, dentists, physicians, and facilities. So I'm sort of on the downstream end of a lot of bad outcomes from healthcare, but I have a really cool job because my job is to figure out what went wrong, why, and try and get out in front of it. And on a personal note, I told Joel, I confided in him that I asked what the format for this was, and he said, you know, we're going to be sitting on a couch. I'm a little guy, and I was worried that my feet would not touch the ground, and I'm happy to report we're all good.
You're good. That's excellent. Excellent.
I'm Michael Mendelson, and I'm also delighted to be here. I'm an independent consultant, been speaking and writing about patient safety for over 20 years. I also hold an adjunct appointment at Northwestern University's Feinberg School of Medicine. And I wrote a book called Demanding Medical Excellence, Doctors and Accountability in the Information Age back in 1997. And in the early 1990s, while I was writing that book, I discovered the toll taken by medical error, and that there had been articles in the medical literature about the systematic presence of medical error, and 100,000 people dying, 180,000 people dying in the 1970s, in the early 1990s, and that really nothing had been done about it. And I was writing about that before the Institute of Medicine discovered the issue. And after the Institute of Medicine did its report in 1999 to Errors Human, I wrote an article called The Silence that said, listen, you talked about up to 100,000 people dying every year, and you're not doing anything but giving out speeches with PowerPoints about medical error. Why don't you do something about it if this many people are dying? And finally, 2 years later, the Institute for Healthcare Improvement did its Save 100,000 Lives campaign. So I think it's really important that what we're doing here with a goal, zero preventable harm, which is absolutely reachable, zero preventable harm, and that we take a look at the cost issue, which I know we're going to talk about more as part of that. And while we were in the waiting area, Joe and I were talking, and I sort of have a way of looking at the economic impact, which I think is really important. And it's building on something that President Johnson said in a different context, in a more obscene way. Grab them by their wallets and their hearts and minds will follow. And I think that if we grab this issue by the wallet, hearts and minds will follow, behavior change will follow, and we can do what all of us want to do.
Doctor.
Yes, hello everyone again. I'm Marleece Barber, Chief Medical Officer of Lockheed Martin. I trained in internal medicine, but I found my way into the field of occupational medicine, and my focus in this role is to understand the impact of health on individual and organizational performance. And when we think about medical errors, the implications are huge, not only for worker productivity, but the cost to the corporation in leave of absence, disability, workers' compensation. So it has profound effect, paramount though, the viability and the productivity of that individual, the patient employee.
Leah.
I'm Leah Binder. I'm the President and CEO of the Leapfrog Group. We are a nonprofit, an independent nonprofit based in DC, and our members are large purchasers of health benefits, including Lockheed Martin, actually. And we are aiming to generate a market for safer hospital care. The original founders of Leapfrog were in 2000, so right after the IOM report that Michael just mentioned. They were committed to reducing the number then, which was 100,000 preventable deaths every year. That was the number then. Unfortunately, we have better data now that suggests it's at least twice that. But they said, we believe that our employees are entitled to know how hospitals are doing and how safe they are. We're going to put out a report card, and we're going to ask hospitals to give us the information we need for the report card. At the time, in 2000, that was basically a crazy idea. It hadn't been really done at the national level. It was just an idea, but they did it and put it out for starting with 200 hospitals. Today we have over 1,500 hospitals participating voluntarily, providing information on their safety and quality, which we make public at no cost. 3 years ago, however, and because not all hospitals voluntarily provide that information, we started a new initiative to really engage consumers, because it became quite clear to a lot of our members that their employees really had to be personally involved with choosing hospitals based on safety. We had to find a way to reach them better than we could do. So we started issuing a letter grade to all general hospitals in the United States. It's an A, B, C, D, or F, and we do issue Ds and Fs included in that list for how safe hospitals are for their patients. And that has been very successful. We've gotten a lot of consumers engaged with that, and a lot of employers. In addition, employers have been very interested in looking at their own bottom line and trying to understand, to the point of this panel, how much is this really costing us? How can we lower these costs? But the cost being not only in dollars, but also in the lives and health and productivity of their employees. So there's a really, I think, growing interest by employers figuring out how to take a positive approach on this issue and really make a difference.
So let's separate out the human toll, or the human cost, the loss of life, and those types of issues, from the economic cost. And let's try to get into and try and quantify who's paying for medical errors. And why don't we just go straight down the line here. Give us your perspective, who's paying, and can you quantify how much is that?
Sure. I think aside from the human toll, certainly what I'm seeing on a day-to-day basis is, and I think we ought to have a frank conversation about it, between 8 and 12% of the healthcare dollars spent on defensive medicine. And these are tests that physicians and other providers are ordering, and they're ordering them out of the fear of litigation. And I would argue and state that a lot of those testing is not necessarily benign. Whether it's CT scans, whether it's cultures. And so I think there's a tremendous financial cost, and employers are trying to get their arms around that. So I would just start there, that we ought to be having a conversation about what we're going to do about defensive medicine costs, because there are a lot of medical errors there, and there's a huge financial cost as well.
Interesting. Okay. Michael?
I think the panel really starts to answer that question, right? Because medical malpractice companies have become tremendously proactive, at least the best of them, at helping to prevent medical error, because they see the premiums going up, and they see it as a risk, and they see it as a financial risk to their clients. At the same time, employers, certainly led by the Leapfrog Group back before it was very popular at all, and some of the larger progressive employers are saying, listen, it's our cost, it's our people, it's our insurance premiums, it's our human cost. And I think those are the key. Unfortunately, the financial incentives have been so that medical error, to a certain extent, is a profit center for hospitals. Now, I want to address something you always hear, which is that quality is free. Not true. It is cheaper to either kill them or cure them the first day. And so what I used to tell to employers is, listen, if you injure them, that's where the problem is, right? So quality is not free. But injuring people, hurting people, presenteeism, all the rest of that has an economic cost that reverberates throughout the system and continues to reverberate. And I think what is so incredible about what's happening is, if you have the malpractice people, you have the employers, you start to have some of the insurers there who listen to the employers, you start to have a united front that says, we are not going to absorb the financial cost here. And that's really important, because again, money drives the system. People have good intentions, money gets their attention as well as those good intentions.
So kind of just to follow up with that, so as I indicated in my initial remarks, Medicare made a positive change in policy to say, we're not going to pay for that.
So the Medicare change is incredibly important, and I think that this is a bipartisan, actually, congressional success that is not very well known at all, except among policy wonks, because it's not conflict, it's success. So the Bush administration has in 2008 a policy not to pay for never events, right? Certain infections and all that is never events with healthcare associated conditions. And it starts before that, but it takes effect in 2008. We continue to go forward, and we have in the Affordable Care Act, under the Obama administration, we strengthen the definition, we put more things on the list, we have more financial penalties, and you start to see a change in the industry. There's an article that came out in the medical literature just a couple of weeks ago, actually, that looked at the financial impact of that 2008 change going forward, and we saw that hospital-acquired conditions, a euphemism if ever there was one, CLABSIs, bloodstream infections, urinary tract infections, catheters go down 10 to 11%. What this tells you is that government, acting not as a regulator, but as a payer, something the Bush administration and the Obama administration both supported, caused thousands of people not to be injured, and many of them die from bloodstream infections by changing the financial incentives. That's an important story that needs to be told. It's been reinforced by the private sector. And I'll just add one last thing about the importance of government. Because I used to be a benefits consultant. And when the Bush administration came out with its regulation on never events, I said to a colleague who was with an insurance company, I don't understand this. I believe in the private sector. The private sector should be protecting corporate clients like you. Why didn't Aetna and Blue Cross and all the rest of those folks come out with this policy before the federal government? And it was explained to me that if any one insurance company had tried to do this, they don't have enough of a market share. And the hospitals would have pushed back and said, you can't do this to us because you need us in the network. And the public just sees whether we're in the network. You can't do this. When the government did it, the hospitals need Medicare more than Medicare needs the hospital, and then all the private insurers followed suit. So this is government as payer, private people as payer, financial incentives, lives saved, a story that's not told.
So I'd like to get the employer, big employer perspective, especially
Yes.
the folks who are self-funding. Are the employers generally still paying for things that Medicare will no longer pay for, like these never events?
Generally, yes. So if you look at the way most people receive insurance, it's through an employer, and Lockheed Martin, like many other large companies, is self-insured. So any cost, anything that is billable to insurance is really the company's cost. So they pay the claim, they pay for the coverage of the employee when the employee is, if the employee is harmed and away from work, we pay for their disability insurance. So we're also paying for the extended stay away from the work. We also then have to hire someone to replace the person when they are out of work. So you have extra temporary workers perhaps filling in for patients who've been injured. So the implications for the employer, the cost, are significant. One of the things, though, that I think that we can learn a lot about, having grown up in occupational health, is what took place in industry. And I shared this with many of my medical colleagues early on in my career that I guess it was maybe even before 2000, the safety culture in industry started talking about target zero and how they were going to have no injuries in the workplace. I thought it was preposterous. I mean, how can you prevent all injuries? Why would we even set such a goal and when we're going to fail? But what I have seen is how it actually transformed the workplace. It gave us something to rally around. It gave us something to focus on. It began to dictate our meetings. So when you have supervisors and directors and the CEO beginning a meeting wanting to know what are the statistics on our safety, it drives certain behavior. And I think that there is a lot more synergy there, and we can learn a lot from each other.
So the cultural aspect to this is a significant incentive or driver.
Yes.
Okay. Yeah.
So the question is, who pays?
Right.
And the answer is the second biggest payer, I'm going to start with the second biggest payer, as far as I'm concerned, are the purchasers. So meaning mostly employers, but also some unions that manage their own health benefits. But large purchasers pay, and they pay the most by far. So I'm going to give you one example of how I substantiate this thought. And back in 2013, JAMA had a study that was done by a group of researchers, one of whom was Atul Gawande. And they looked at a southern hospital system, and they asked the question, how much do different payers pay every time there's a surgical site infection? And this actually took months of research. So anyone who thinks that employers can just go to their claims data to figure out how bad the safety situation is has another thing coming. You cannot find it from the claims data. It's very different. And so it took these brilliant researchers 9 months or something to figure out how much extra was paid. Okay, so Medicaid patients, Medicaid paid on average $900 extra, which is a lot of groceries for a person on Medicaid, paid for a surgical site infection. By the way, this is not the cost of whatever treatment caused the patient to be admitted. This is just excess costs related to this surgical site infection. Medicare paid $3,000, also a lot of money. I don't think any of us would really want to be writing a check for $3,000 for the privilege of an infection. But here's the big one. The commercially insured, meaning purchasers, okay, that's purchasers pay for the insurance.
60% of the population, 190 million people, right? The commercially insured. About
Yeah, depending
185,
on
190,
something like that.
Yeah.
Okay, but they paid on average for that surgical site infection $39,000.
Wow.
Okay, so 900, 3,000, $39,000. Now, I think that a lot of jobs could be created in this country that just went to pay for a surgical site infection. So that's who's paying. But I said that's the second highest payer. The number one payer in terms of dollars paid for these infections and for problems and safety problems is the American consumer. They really don't know it. But the number one group of spenders in healthcare, according to all the actuaries in CMS, the number one spending group is consumers. So they are actually paying through their premiums, through their out-of-pocket costs, et cetera. They pay. And those costs are shifted to them through a variety of means that are not easily trackable. So I want to say one other thing that I think we've looked at closely in understanding how we're going to get at this problem once we know who's paying. First, we have to know who is paying and how much. Right. That's been the biggest problem. So we actually put together for our members, and for everyone, actually it's free, a calculator of the hidden surcharge Americans pay for hospital errors. And it's a way that you can go in and we use the data that we have, which isn't enough. It's a very conservative calculator that just allows you to estimate, make your own assumptions, but estimate how much it costs for an employee to use a hospital that does well on, say, central line infections versus one that doesn't. And you can calculate in a variety of ways. But on average, we find that employers pay, on average, on $8,000 per employee for every admission. Not just the admissions that have problems, but every admission on average, $8,000 minimum for the cost of the errors and accidents that happen. And most of what we hear is that that is an incredibly conservative number. So at least, though, it's a number, and it helps, I think, for employers to start to strategize, because once you add up that number and you look at all your admissions, it becomes an astronomical sum of money for something that is pure, it's waste and it's harm. So I think that really gets the attention of employers, and it starts to motivate, I think, some really changes in purchasing behaviors.
Is that something that we know, the dead weight loss there, the absolute drag on wasting money on something that's completely non-productive in terms of jobs or growth or output, anything like that?
Well, I can tell you just anecdotally from what purchasers say, absolutely. I mean, health benefits costs is a major concern for many purchasers. health benefits, they pay more for health benefits than they earned in profits in a given year. Even when the economy was at its worst, health benefits costs still kept going up. So I'm sure a lot of people lost their jobs because when the layoffs were happening, the health benefits costs just never stopped.
I'm going to build on what Leah said for a moment, because I think it's important to understand. One man's cost is another man's income.
Right.
Now, if you're the federal government, if you're the Medicare program, and same thing pretty much besides Medicaid, by law, you cannot keep anybody out of your network. You can't discriminate that way. So Medicare has a blunt instrument. They can reward and they can punish with incentives and penalties, and they have to be careful how much they do because each and every congressman is part of a congressional district where 100% of the hospitals are above average. And I did a piece, you can look at safedistricts.com. I did a piece with some colleagues just a few months ago. We looked at patient safety costs by congressional district. Mortality rate and cost by congressional district, safedistricts.com. Now, private companies, on the other hand, can provide incentives for the hospitals that are good, that keep those costs down, not to lose their shirts. And so the private sector is really important to reward the good folks, and the same with the malpractice kind of rates, so that the people who take their time changing don't make the most money. And that's a really important kind of thing, because everybody wants to do the right thing. Some people do it a little bit more slowly when it costs them something in the wallet. Taking these numbers and saying, we are not just going to take all that money from you, we're going to share it with you, is really important. That's where the private sector is critical.
I want to piggyback on what Michael just said, and let's talk about getting our arms around cost, whether it's incentives, but there's some campaigns out. Most people in the room have heard of Choosing Wisely campaign. Right. So I'd like to throw something out and challenge you as an individual. So in emergency medicine, there are 10 Choosing Wisely recommendations. There's been a huge uproar lately about concussions, whether it's in the NFL or whether it's our children. So let me give you an example, and I want you to really think about this, okay? So it's 8 o'clock at night. Your 14-year-old son just got hit hard in a football game. It's Friday night high school football games everywhere in America. And he's a little woozy, but doing okay, but you decide after the game to bring him to an emergency department. And in that emergency department, there's a 3-hour wait, okay? And your son's name is Johnny, but Johnny is looking okay. And you come and you see myself or one of my colleagues, and Johnny looks pretty good, normal neurologic exam, maybe a little nauseated. And I begin to explain to you that according to the Choosing Wisely campaign, we don't recommend getting CT scans anymore. And I go through the methodology because A, it's going to cost $1,000. B, we don't want to irradiate pediatric heads with too many CT scans. And it's 1 o'clock in the morning, you've been waiting 3 hours, and my recommendation to you is let's not get the CT scan, but the only reason that you came was to get the CT scan. So we have a conversation about that. In the back of my mind, I also know that you're on a high deductible plan. You're probably going to have to pay out of pocket for this visit, and I'm going to give you a patient satisfaction survey on the way out the door. So I do want to ask you a really honest question. I want to see a show of hands. This isn't everybody else's child. This is your child, and there's a very small chance that I may miss something if I don't get the CT scan. How many of you honestly don't want me to spend the $1,000? Raise your hand. Now, the rest of you are all lying.
Few hands.
But that's, when we're trying to get our arms around the cost and the expenditure, that's really where the rubber meets the road. And it's a very moving, fluid dynamic. We understand the science and we can make recommendations, but everybody's got to be on board.
Well, I want to say, I totally agree with you that overuse and inappropriate use is a huge problem, and the data on that are another set of astounding statistics. But it is not the only problem with safety by any means. The biggest problem with safety, I think, is that errors and accidents and injuries, first of all, they happen without any recording of them in a formal way, so that most employers, for example, don't know that they happened. And then when they do know that they happened, there isn't enough marketplace response. So a hospital doesn't necessarily lose market share because they're unsafe. And we see that when we look at, we have hospitals we give an A to, and by the way, we have a free app also, Hospital Safety Score, if you want to look it up. But so you can look at hospitals and look at their grades around here or anywhere in the country. But if we have a hospital that gets an A versus a hospital that gets a D, does the D hospital, are their reimbursements affected at all by being a D versus an A? And the answer right now is no, but that's changing quickly because employers are getting pretty wise to that problem. But there's an interesting, a bunch of interesting kinds of models in the marketplace that are trying to address that issue by helping employers identify these events when they happen. There's something called Patient Protect, which has come out to try to allow employers to invest in some way to help give their employees an incentive to report back that this has happened when they have a never event, because we don't even know that those are happening. So although I agree with you, I think the fundamental problem with safety is we don't know when these events happen, and so the marketplace is slow, if not completely stalled, in responding to these. We have no market for safety. That has to change immediately.
So that's a really important point, I think, and so how do we uncover those issues so that if we know who's paying for these errors, we can maybe use the money as leverage to stop paying for them and maybe disincentivize them? What are the solutions there? What data do we need? How do we expose these events? Do we need to make systems interoperable? What are some of the things there that we can start exploring? What are some of the strategies in the private sector to start exploring?
Well, I think you mentioned very well, which is the incentive for the patients as well. So one of the words I heard here was actionable. The other word I'd like to put out there, because we're going to talk about transparency in the next session, is accountability. And accountability goes across all fronts. It goes in the healthcare systems, it goes in the providers, but it also goes on the patients. So the patients have skin in the game as well, particularly now as many of them are paying high deductible plans. So I think it is the economic incentives. You talked about the economic incentives, and we see this on the healthcare system, where you're going to get reimbursed or you're going to get dinged, and you're going to be measured. And on the provider side, there's also incentives to save costs. I worry a little bit about that in the boomer population, which is impacting all of us right now. There's 75 million people coming through, and we're having conversations, and this is your grandpa who's short of breath and has atrial fibrillation, but was just discharged 6 days ago, and now there's a lot of pressure, a lot of disincentive to admit them to the hospital. That's a very difficult population to manage because they have comorbidity, they're on multiple medications, and an 18-year-old with fever and abdominal pain is very different than an 80-year-old with fever and abdominal pain. And I worry sometimes that the incentive is going to be see them faster, order less tests, don't admit them, and don't readmit them. And I particularly worry about that in that population. So getting our arms around this is complex. It's doable, but it's going to be a multi-pronged attack, not just one solution, and technology has a place in helping that.
So Greg, I think that we need to distinguish between sort of errors in diagnosis, which is what you're talking about because of readmission incentives, and sort of errors in execution, right? So there's one kind of preventability of errors in diagnosis, and the Institute of Medicine report in 1999 doesn't really talk about that. What they're talking about is errors in execution. So I admit that grandpa, and I give him the wrong drug, and I hurt him, or I kill him. And I think also when it comes to accountability financially, patients aren't worried about the money from patient safety, it's their lives, right? It's the old joke about the pig and the chicken having the conversation about ham and eggs and who's more responsible, and finally the pig goes, for you it's a contribution, for me it's a lifetime commitment. And so, for patient safety rankings, patients kind of get it. They have enough skin in the game. But what we need to do is take things like the Leapfrog and other indicators of safety and put that so when I Google a hospital, I get safety things, not just going to some separate stuff. So it's on WebMD, so it's elsewhere. The simplest thing you could do, right? So we know from the medical literature that you cannot give hospitals a grade for quality. It doesn't work. They could have a great neuro department and a lousy cardiac, and it just doesn't work. On the other hand, for safety, you could give a letter grade. just like when you go into a coffee shop or a restaurant and you see up on the wall a grade from the Department of Sanitation. If there was a safety grade up on the wall when you went in, trust me, that would do it. Simple solution, politically might have a few difficulties here and there, but that's the kind of transparency and accountability that we need that shows we're serious about safety and we believe in our measures.
Well, that's what we were trying to say. That is exactly the model we were trying to do with the hospital safety score, but we haven't convinced the hospitals to put it up on their wall.
I wonder why
Particularly
not.
the B's, D's, and they're not happy, but we're getting there.
Well, if the patient really is the person who is bearing the brunt of the cost, I think there's some real opportunities for us to raise the literacy of that population. One of the things that we've started to do in my company is to talk about health and wealth. Large companies are no longer going to continue to shoulder the burden of those costs, and they are shifting it to employees. So I think, in fairness, we have to do a better job of helping them to understand the complexities around this issue. How do you look at a scorecard? What scorecards exist? How do you make decisions about how do you assess a doctor's competency? How can you find out what his success rate is on surgeries and a hospital's infection control work? And an employer should do more to educate their employees in that area.
So we've got a bunch of questions from the audience, which is I'm not surprised by. So one of the overarching questions, I think, from a number of different people is, why is it that employers are paying so much more than Medicare or other public programs for the medical errors? Maybe a question for Leah there, or Doctor for you.
I think employers are probably paying more because we see the employee every day. And one of the things that employers don't like to have is what we call noise. So angry letters about a claim not being paid, it really does resonate in the organization. So I think we continue to really try to make sure that our employees are getting good service. And as a result, sometimes probably pay for things that we may need to take a stand on.
But I think if the question is related to my earlier citation from JAMA of the $39,000, why are employers willingly paying $39,000? Gets to this issue of, because they don't see it. They don't know, even though they just know they're paying a lot of money for health benefits, and they don't understand necessarily why. They're trying to figure it out from the claims, but it's not obvious. So here's why. So for example, if someone goes in and gets a surgical site infection, they're going to have a longer length of stay. There's going to be some other treatments involved. They're going to get a lot of bills and claims for those particular extra services. But it's not necessarily going to say, this was because we had a surgical site infection. Same for any other kind of error. It's not going to say, because we gave your employee the wrong medicine on Tuesday, and he had to stay the rest of the week, and so we could treat him to, it's not going to say on the claims, this is because we screwed up. It's just going to be extra costs, and employers just don't realize that that's what it's for. And they're changing, and that's changing. Yeah. But that's why they formed something like my organization to ask hospitals, report on those errors directly. We can't get them out of the claims. You tell us when are these being made and how are we going to identify them. And that's one of the tricks with patient safety, is getting those errors identified. We've gotten much better at it, not just Leapfrog, but the federal government, and that's why we're able now to do some ratings that I think are going to protect patients. But employers are very vulnerable to it if they're not really pushing to force their plans and to force others to tell them where these errors are actually happening.
So it's really the identification of those errors and figuring out systematically how to put a
how to be
value
aggressive
on that.
in their purchasing. So they say, I know you had a lot of errors there. I want to stop paying. We have a never events policy that the employers at Leapfrog agreed on and signed on to it. Hundreds of employers sign on to this never events policy that says we're not going to pay for these errors. If for certain, there were 28 of them identified, they're horrible things like leaving objects in after surgery. We're not going to pay for the consequences. But think about what was crazy about that, and is crazy about that, is that we ever had to have a never events policy. Do you have a never events policy in any other industry? Do you have a never events policy for cars? If you have a car that explodes on people, we're not going to pay you for the, you don't have to have a policy for other industries. If there's a never event that happens in another industry, it's accepted and it's expected that the customer does not have to pay for the consequences of that injury. But in healthcare, we actually have to stake the claim and say, no, wait, we're not going to pay that. The hospital should absorb the cost of these terrible errors. That has not happened, and that's one of the major problems in our healthcare system.
I think you're going to see a huge shift in technology, too. This is a very target-rich environment for innovation, but one of the things that I see is 50% of the bad outcomes that I see have nothing to do with the clinical decision-making of the clinician or the physician, but everything to do with the environment that they practice in. And so when we turn off the alarm or we give 10 times the dose of potassium and we harm somebody, none of the physicians woke up in the morning and said, you know, today I'm going to harm somebody. It's not the way it works. But the question should be, and I think there's been huge discussions and a lot of incentives from the employers who are paying for this, is let's design a system where we don't allow that to happen. Why is it that you're allowed to turn off the alarm? Why is it that you are functioning and practicing medicine in an environment that allows you to make an error? And that's where I really see the next wave of technology, is designing things that prevent this stuff way before it happens, and that'll save everybody money.
And that's part of the culture shift that we've been talking about. I mean, so the physicians traditionally, and of course that's been changing over the years, did not see that it was the environment. It was that I am the best and the brightest, I'm responsible, I'm accountable, I know what I'm doing, and I'm going to make sure that it's a safe environment. And if something happens, well, stuff happens, right? And now with some of the financial incentives, we're saying, you know what, you're smart, you work hard, but stuff happens because you haven't designed your environment right. It's not the nurse's fault, it's not even really your fault. Let's design a high reliability organization, as our friends at MedStar I know are doing. The other thing, just briefly on the insurance, part of the reason commercial insurers are paying more is commercial insurers pay more, right? So if you do something lousy to a Medicaid patient or good to a Medicaid patient, you get pennies on the dollar. Yeah. If you do something good or lousy to a well-insured patient, you get paid more money. And some of the commercial insurers have traditionally been a little bit laissez-faire about doing anything that disturbs their comfortable relationship with some of the providers that they've worked with for many years.
And another real opportunity in the area of innovation, my company and many other innovators have created virtual rooms where you can create settings that are very much like training atmospheres that would have been really beneficial for me when I was going through. But these virtual rooms allow practitioners to go in and pretend that there is a distraction in the background, and it really lets you know how a nurse could have given the wrong dosages because they were intending to do something and someone called their name. But if you get into the habit of knowing what's first, what's second, and how to anticipate distractions and how to get back on task, it helps you to perform more reliably in a real life setting.
And by the way, I don't know if your company talks about this, but Lockheed invented one of the first electronic medical records. So the first electronic medical record came from Lockheed, and the reason was after the moon landing, when the space program went downhill and all the funding went, they said, you know what, if we can use computers to put a man on the moon, why don't we use the same expertise and invent an electronic medical record? Surely doctors will adopt that. And Lockheed, actually a former client of mine, El Camino Hospital down the road, they used the first medical record from Lockheed, which then eventually sold that business. So if we can put a man on the moon with computers, surely we'll have interoperable medical records by what, about 1973?
Yeah. That was my learning moment of the day.
So I want to follow back up with you, and the issue is that we're not identifying the claims as they come across the transom when we pay for them, right? Can you talk a little bit about then what your approach is to rating the hospitals and how that all works out? I don't need to get into a huge methodological issue, but just talk a little bit about that.
Well, so for the letter grade, we have sort of two things, but the letter grades, we started by bringing together top experts in patient safety, so like Peter Pronovost and Lucian Leap, who's one of the founders of the movement, just some really what we call a dream team experts on patient safety. And we asked them, looking at all of the data we have on patient safety in hospitals, which is limited, unfortunately, but all the data we have that's publicly available by hospital, which of these measures are most impactful and worth using in a composite. And over a period of months, they selected them based on the evidence and impact. And then we ended up with 28 measures that are publicly available, mostly through CMS, some through the Leapfrog survey that I mentioned earlier we do every year. But if hospitals don't report to Leapfrog, they decline to report, then we don't use that information. It doesn't help or hurt them, but just gives us less information in the composite. And then now those include two kinds of measures, particularly outcome. So how infection rates, so you mentioned CLABSI, UTI infections, et cetera, and never events, such as objects left in after surgery, most of that coming from CMS. Then we also have in that composite process measures. So do they take the right steps before surgery? Do they issue out antibiotics at the right time? And to what extent do they do that? And we have a set of safe practices. Do they have a hand hygiene policy passed by their board? Do they have a nursing workforce policy known to be the safest? Those kinds of questions that we ask about. Do they have in place the right structures that will prevent errors from happening? And we ask a question about technology as well. Leapfrog from the beginning asked hospitals in our survey, do you have CPOE, computerized physician order entry, which is known to prevent medication errors, which are the most common error in hospitals. And we now have an even more robust way of asking the question. We actually have hospitals test to see if those systems work well to prevent errors by picking up common errors like allergy interactions. A third of the time they don't, so just FYI, technology has to be monitored. But in any case, we ask them about CPOE and whether that system works. Those are our process measures. We put them all together in a formula that is all made public. And then underneath the letter grade, consumers and anyone who wants to can go in and look at exactly how a hospital did on every one of those measures. So we're very, very transparent about how we do this, and so they can decide for themselves. If they think that what we think is important isn't as important to them, but another thing in our score is more important, they can look and see for themselves how this hospital did. But that's how we put it together, and again, transparency is really important to us. I think it's really important to most employers. For too long, I think the healthcare industry has functioned in a way that doesn't value transparency, doesn't value the idea that we should lean toward transparency, put out as much information about our performance as possible. Not only is it good for us as an organization, but it is certainly good for the purchasers and those who are our customers.
So let's switch focus a little bit. We're getting low on time. We spent a lot of time talking about hospital setting. Patients are discharged, they go home, they see their doc. A third of healthcare spending is hospitals. Another third is physicians and other ambulatory providers. 10% is medications. Medical non-adherence, medication non-adherence is $100 to $300 billion problem every year. You don't take the pill, you have a heart attack, you go to the hospital where maybe a medical error gets you. But where are the opportunities outside the hospital setting? And what's the next step to starting addressing the costs there?
I just want to say that one of the things that is a huge opportunity is to study that. We have not looked at outpatient safety. We have no comprehensive look at outpatient safety in 2015, after all the studies we've been looking at hospital safety since the 1950s and then a little bit more since then. Right? Nothing comprehensive, a few things. We really need to do that. With medication, we know that medication issues have a lot of people end up in the hospital. So we have some idea about community dwelling people, but we really need to have the research. And I think it's good that you brought up that the patient safety movement addresses patient safety everywhere. I think that's really important. And certainly I'm sure it has malpractice implications everywhere.
Yeah, I think let's just be really frank. If you do everything right when you discharge a person from an emergency department, you give them their prescription, or you call it in the pharmacy, you give them pre-printed discharge instructions in their own language. You have a discussion with them, you call and make an appointment with them, and you discuss with the family, you get 50% compliance. So it is a very difficult challenge, and that's for many reasons. Maybe they can't afford the medications, maybe they can't get in to see somebody, but all of that stuff is going to get tracked. There are now some incredible innovations. There are electronic pill capsule tops that say when grandma took her medications, that phone that into the physician clinicians in terms of measuring compliance. You're seeing a wave of prevention on narcotic prescriptions. It's a huge problem. We have adolescents getting into grandma and grandpa's taking narcotic medications, so there's a huge focus on giant patient safety effort to do that. So we will get better downstream, but managing populations of patients outside of the hospital is something, it's where this is going. People have wearable technology, okay? But that's generating gigabytes of data that's coming in that somebody's got to monitor, screen, and we've got to look at that and make sure that we have systems in place to identify when somebody has, a cardiac dysrhythmia at home. Who's gonna own that when they're not in the healthcare system? So that's the way it's headed.
And maybe integrating remote monitoring into that cycle to be able to identify those things. Doctor?
The other phenomenon is more and more large and mid-sized employers are offering on-site care. And where we fill the gap is we have the luxury of having a 45-minute, even an hour encounter with an employee. And we really try to take that time to get our patients with chronic disease to come in and let us routinely check their blood sugars and their blood pressure and give them some advice, sort of partner with them. And it's a different dynamic when you're working with a colleague. They trust us, and we have the ability to see them much more frequently. We don't want to replace the primary care doctor, but we certainly want to be an adjunct, and we advertise those services.
An hour per patient? I'm going to come work for you.
You guys can talk afterwards. So last question, I want you to be thinking about this while I ask the question. Lightning round, be solution focused. What's the number one thing that you would do to lower the costs related to preventable errors? And we'll just go right down the line.
I would embrace human factors engineering and design systems that make it safe so that we would prevent this stuff from ever happening.
Interesting. Michael?
I would have much improved transparency so that it would motivate people to go look up all the great methods that Graham has invented.
Excellent. Michael? Doctor?
Certainly patient education, but as I mentioned, I think there's a lot to be learned from industry and safety, so I agree with you.
Leah?
Well, Michael stole mine.
Thank you. Let's have a, no, go ahead. Are we?
Okay, I would have employers, every employer in America using the information they have access to and demanding that transparency for their employees.
Excellent.
Well said.
Let's thank our panel. Really great job. Fantastic.